Today, we'll discuss Parkinson's disease, including how it's assessed, diagnosed, and managed. This is a key topic for any nurse preparing for the NCLEX, and one that shows up often in clinical practice. Parkinson's is diagnosed clinically. There's no single test or scan that confirms it. Diagnosis is based on a thorough history, physical exam, symptom progression, and how the patient responds to medications, especially levodopa. To meet diagnostic criteria, a patient needs to have at least 2 of the 4 hallmark features: tremor, rigidity, bradykinesia, and postural instability. Bradykinesia means slowness of movement, and postural instability often shows up as a shuffling gait or balance issues. These symptoms may creep in slowly, and often it's family members who notice the changes first. Things like reduced arm swing, softer speech, or smaller handwriting. Another important tool is the MDS-UPDRS, the Movement Disorder Society's Unified Parkinson's Disease Rating Scale. It helps providers track disease severity and symptom progression. An improvement in symptoms with a trial of levodopa is often considered confirmatory. There is no cure for Parkinson's. Treatment focuses on controlling symptoms and preserving independence. Most patients are managed at home, and care plans are tailored to their specific symptoms and needs. Pharmacologic treatment centers around restoring the dopamine imbalance in the brain. The gold standard is levodopa, which converts to dopamine in the brain. It's usually combined with carbidopa, which prevents it from breaking down before reaching the brain. This combination is highly effective, especially early on, but over time the effects may wear off or become inconsistent. Patients may also develop dyskinesias. Those are involuntary movements that happen when medication levels peak, or they may experience the on-off phenomenon, where the effects of the medication seem to suddenly stop and start again. Because of this, providers often delay starting levodopa and instead begin with other classes of medications. Anticholinergics, like trihexyphenidyl and benztropine, are used to control tremors, especially in younger patients, but they come with side effects: dry mouth, blurred vision, urinary retention, and confusion, so they aren't ideal for older adults. Amantadine, originally developed as an antiviral, can help with rigidity and tremor. It may cause mood changes, hallucinations, or leg swelling. Dopamine agonists like bromocriptine, ropinirole, and pramipexole act like dopamine in the brain. They're often used early in the disease or in combination with other drugs. MAAOB inhibitors, such as selegiline and rasagiline, slow down the breakdown of dopamine in the brain, helping extend the effectiveness of existing dopamine. COMT inhibitors like entacapone and tolcapone work similarly, helping levodopa stay active longer in the system. These medications can be used alone or in combination, depending on the patient's needs and how they respond. When medications no longer provide enough relief, or the side effects become too difficult, surgery might be considered. The most common procedure is deep brain stimulation, also known as DBS. DBS involves placing a small electrode in a specific part of the brain, usually the subthalamic nucleus, or globus pallidus. This electrode is connected to a pulse generator implanted under the skin near the collarbone. It delivers electrical impulses that reduce tremors, rigidity, and other motor symptoms. To be eligible for DBS, patients typically must respond well to levodopa, have had Parkinson's for at least 5 years, experience significant motor symptoms, and not have dementia. While DBS doesn't stop the disease itself, it can improve quality of life and help reduce reliance on medications. To summarize, Parkinson's disease is a progressive disorder caused by a loss of dopamine-producing neurons. Diagnosis is based on clinical findings, with levodopa responsiveness being a strong clue. Key symptoms include tremor, rigidity, bradykinesia, and postural changes. Treatment is centered around dopamine replacement and symptom management, with surgical options like DBS reserved for advanced cases. As nurses, we're not just managing medications, we're supporting patients through changes in mobility, independence, and emotional well-being. Understanding the condition helps us offer better education, anticipate complications, and advocate for care that actually fits the patient's life.